I'm here representing my colleagues from St Mary's Hospital in London, and I work with an amazing group of people, and one of them is Caroline Foster, who's set up this pediatric virtual clinic, and we receive referrals from all over the place, and I'm very, very happy to discuss them. And I'll be referring to our pediatric virtual clinic, the PVC, as we go through the case, because it was really important to put our heads together and think what to do. So this boy was actually born in a sub-Saharan African country in 2011, and the story was confused, but the mother said that she had actually been tested twice in pregnancy. One of the tests was positive, one of the tests was negative. Her husband was tested and he was negative, and they chose to believe her negative test. And she went through, had a spontaneous vaginal delivery, BCG was given, immunizations according to national policy, breastfed until about 1.5 years of age. The child was hospitalized with malaria at around 20 months of age. And that was a 3-day admission during which the child needed treatment for thrush as well, but apparently was not tested for HIV. And then the family moved to the UK in February 2013. And during the next few months, it was clear that there was an issue with this child's appetite, there was faltering growth, there were developmental concerns that our GP was, the primary caregivers were a bit concerned about. And in November, which was undoubtedly a little late, this girl then presented with 5 days of cough, was treated with amoxicillin orally, and admitted to one of the district general hospitals with bilateral pneumonia and acute respiratory failure. So got started on a broad-spectrum antibiotics, intubated, ventilated, and transferred to a pediatric intensive care unit at a tertiary referral hospital, not our hospital, where ET secretions were taken, and amongst other problems was PCP was identified at that point by PCR. But a lot of other things were going on. They very rapidly got the evidence of HIV infection with a very high viral load, and a CD4 count that's 250. I mean, the child is 2 years old, so that's obviously very low, but a reasonable percentage. CMV viremia. A quantiferon gamma was done, which was indeterminate, but there were no AFB on ET secretions. There was no growth on blood cultures. There was a treponemal antibody that was reactive, but no evidence of active syphilis, and all the hepatitis screen was negative. So the child was transferred to our center, and in fact, that respiratory illness recovered pretty quickly, extubated within 72 hours. The oxygen requirement resolved over about 10 days. The child was treated with IV cotrimoxazole and steroids, and subsequently was put onto prophylaxis, but with a little bit of caution in the back of our minds, because there was so much else going on. And in addition, we were treating the CMV with ganciclovir. We did a few investigations. Obviously, the HIV subtype is there, and the child was HLA-B5701 negative. Baseline resistance testing, wild type. I mean, I suspect many of these tests would not be immediately available outside a very well-resourced setting. And I just want to get to the meat of the case, because what we did was to start treatment with a 4-drug cocktail that we've used over many years, and then unfortunately within a short space of time the liver function test went off, and we worried that that was due to the nevirapine. Whoops. So we stopped the nevirapine and started raltegravir at that point. And 10 days later, so we're now about 6 weeks into the whole of this illness, actually, just 4 to 6 weeks later, new onset of fevers, and the child was not feeding, and the BCG site became seriously inflamed with axillary adenopathy, subclavicular mass, hepatosplenomegaly, and persistent transaminitis. So we felt at that point that we were dealing, no prizes for guessing this is a mycobacterial co-infection session, that we were dealing with BCG iris. And indeed, the blood cultures became positive for M. bovis. So my first question is, what treatment would you advise at this point?
We would start the child on a regular TB treatment, but knowing too well that the PZA is probably not going to be effective. The challenge would be what we do with our antiretroviral therapy. So I can't remember, the nevirapine was removed.
Well, we'd stopped the nevirapine. Charles is now on abacavir, lamivudine, zidovudine, and raltegravir.
Okay. So, yeah, we would probably then, just start on a regular tuberculosis therapy and maintain the abacavir 3TC and the raltegravir. Probably we may have to adjust the dose of that one. Yeah, I think that's what we'll do.
Yeah.
Mm-hmm.
Thanks. Anna, maybe I could, if you want to comment from a UK perspective, do you agree with the management that happened so far?
I mean, if I was in Zambia, I probably would do the same. In the UK, we have got more variety of drugs, and knowing that BCG or M. bovis is naturally resistant to pyrazinamide, we wouldn't use pyrazinamide in the combinations. We don't also have fixed dose combinations for anti-TB, and therefore we use single entity drugs. Unlike in Zambia, for example, when you have fixed dose combinations, so single entity is very difficult to find. So yeah, I would go for isoniazid, rifampicin. I'll talk about it maybe a bit later. No pyrazinamide, ethambutol, and instead of pyrazinamide, some clinicians would choose the fourth drug or go with the 3 first. But you have to remember that BCG or M. bovis, different strains have got different resistance or susceptibility patterns, and there are some strains that has got low level resistance to isoniazid, and also some strains have got higher MIC, so higher minimal inhibitory concentrations for rifampicin. So ideally, in an ideal world, you would like to know what kind of strain it is, because, for example, Danish strain is resistant to ethionamide and has got some resistance to isoniazid. So you have to think about doses of isoniazid, and I'll go for higher doses, like 15 to 20 milligrams per kilo. In terms of rifampicin, the child is on raltegravir, so it will be you're expecting drug-to-drug interactions. In adults, there is different recommendations. I think US guidelines say to double raltegravir, whereas European guidelines say not to double raltegravir. But there is, of course, drug-to-drug interactions. As a 2-year-old child, you would expect low levels of, that rifampicin will influence raltegravir. So either you will go for therapeutic drug monitoring, or whether you would choose rifabutin, which is actually also active against M. bovis. It depends on your settings. And also thinking about the fourth drug.
Yeah. Thank you very much. So in fact, we chose this combination of isoniazid, rifabutin, ethambutol, and moxifloxacin, and we hoped that we were going to get away with not having to modify the dose of the raltegravir. And we also, bear in mind this child's on steroids, these were weaned off over over a period of 3 weeks. The child was still in hospital in January, so this had all started in November, and the viral load was increasing at this point, despite it had come down, but then had gone back up again, and we did exactly what you suggested of therapeutic drug monitoring, resistance testing for HIV drug resistance. We already knew that the M. bovis was actually sensitive to isoniazid, and the TDM for raltegravir revealed subtherapeutic levels. So the raltegravir dose was increased. There was no evidence of integrated resistance, and we restarted nevirapine. And obviously, the next problem was neutropenia. We'd seen a bit of this early on when the child was on cotrimoxazole and ganciclovir, as you would expect. But at this point, we stopped the dapsone, first of all, because we actually weren't totally convinced about the PCP in the first place. It had never been identified in our own laboratory, and the recovery had been very quick. We discussed it at the Pediatric Virtual Clinic, and at that point, as I say, the viral load had plateaued, and we didn't feel as though we were getting anywhere with the raltegravir. And so at that point, we switched to Kaletra. I mean, thinking again about all those drug-drug interactions, and we thought we would carry on with TDM for both lopinavir and the nevirapine. I mean, you may well ask, why on earth are we using quite so many antiretrovirals? But we were not winning. We're now 4 months into antiretroviral therapy. And we had to adapt that a little bit further, but we were dealing with this. The biggest problem was the ongoing fevers after the steroids were weaned. This child had extensive bilateral axillary and cervical adenopathy, had chest wall abscesses that had required surgical drainage. The BCG site was remaining inflamed, and this was despite all of the anti-mycobacterial regimen. So at that point, 4 months into therapy and on this concoction of anti-mycobacterial drugs, I'm really interested to know what you would do.
Sharon, what would you do?
You know, I was thinking that you were going to go back on the steroids. I thought that that was certainly something we would have considered. I'm glad that nothing else grew from any of these biopsies, so there wasn't a hidden or second pathogen that we certainly worried about. You know, I saw that you were doing some therapeutic drug monitoring. Was this child home at the time, or was he back in the hospital, and are we sure?
No, this child has not left hospital yet.
He's not left, so we're sure he's getting all the meds.
Absolutely, yeah.
That, you know, it's not like mom's giving him some of the meds some of the time, etc. I'm not so sure that the Moxie is where I would have gone. I think I might have picked other drugs instead of the Moxie. I'm not so sure that we have the right dosing for Moxie in a 2-year-old. And I think that A, I would have done therapeutic drug monitoring on it, but B, I'm not sure I would have picked the Moxie as the drug I would have used in this age group.
Do you want to comment on that, Anna?
I think I mean, we don't know Moxie drugs for 2-year-old, but we could use Leva. You know, I probably will go for levofloxacin in this case. Sorry, I was actually at the Imperial at the time, but we didn't. We thought that Moxie is more effective, and but it's only 4 months here. You said 4 months into treatment, and this is a very slow infection, so we would anticipate a very long treatment anyway. So you would talking about treatment failure when you're reaching, like, I don't know, 6 to 8 months and no response, and or at least at 12 weeks and still bacteria or BCG bovis, Mycobacteria bovis in your blood. So I would carry on. I would press on with whatever you're doing and assure that there is right levels of the drugs and they're given. Yeah, they're given.
And in another setting?
How about you, Chisala? What would you have done?
It's a tough one. Okay, I was thinking I'll probably want to make sure that this child is taking the drugs, but then he's in hospital.
The child's still in hospital, so
yeah.
definitely
And then
adherence.
also, are there any other ongoing opportunistic infections, any other comorbidities that I would want to address? And then I don't know. I don't know that we mentioned whether we have a drug susceptibility testing for the bovis.
The
So
bovis was sensitive.
yeah.
We knew that it was sensitive to isoniazid. I mean, actually, the rest of the drug sensitivity testing is not a very well. It's quite hard to look at the in vitro activity of drugs and translate that to in vivo activity. Yeah. I think that's still true.
Yeah, as I'm given all that, I think I would probably give this child a chance and continue with the ongoing therapy, especially if the therapeutic drug monitoring is showing that there's adherence and everything is going well, and there are no ongoing other opportunistic infections.
Yeah, I think for the audience, what I wanted to get across was the fact that this was a very, very long-running problem. So we tried various things. We tried thalidomide, and we did indeed, because the thalidomide actually didn't do anything at all, restarted prednisolone. So we were thinking about how to modify that iris response. And it was in response to the steroids that, well, to be honest, we were still dealing with suppurative chest wall lesions, and the child had multiple surgical drainage attempts. But what was really interesting was that after March 2014, we didn't have any positive cultures. The auramine stains were negative, the 16S RNA amplification was negative, and the cultures were negative. So we were achieving something with the anti-mycobacterial treatment, and the viral load eventually reached undetectable, and we dropped the nevirapine, and the CD4 counts were above 2,000. So you can see, I'm not quite sure what was going on at that very early blip of the CD4 count, but basically it was a very, very slow rise in the CD4 count systemically, and I don't know if you can see the ages when these bloods were being taken. Obviously, I didn't put the first viral load on that scale because it was way, way, way off the scale. But it took an enormously long time to get this child to undetectable. I mean, actually a period of, it wasn't until early 2015 that we got the child to undetectable in terms of viral load. So the child ends up, as of May last year, on this group of drugs. So still on 4 drugs for HIV and 4 drugs for the M. bovis, and we tried montelukast, and that hadn't made any difference. And at that point, the pediatric virtual clinic talked again, well, a little bit later, and basically they felt we needed to phone a friend, and the friend that we phoned was Mark Cotton. And I thought that was because, at this stage we realized that you guys had got far more experience of this than we had, and Anna made the point that this, 4 months into treatment, you shouldn't be panicking. But 2 years downstream, and we're still dealing with this non-infectious post-complication. Well, apparently non-infectious, we couldn't grow it anyway. And so let me stop at that point and just see if Mark can remember what he said. No, you can ask the panelists.
Do people agree with me? Would you have continued treatment? Patricia, what would you have done?
I mean, one of the questions was, we're not growing the mycobacterium anymore. Maybe this is just purely some horrible, persistent inflammatory reaction that's not driven by the M. bovis, or it's only dead M. bovis.
For me, for the TB treatment, we need to stop because it's too long. It's too long, and as you said, for the bacteriological tests are negative. So for me, we will stop the TB treatment.
Stop the treatment?
Yes, the TB treatment.
Can I ask you, Salah, would you stop the treatment?
I'll probably stop it as well, especially that your cultures are now negative.
Sharon, would you stop or would you continue?
Boy, I don't have an answer for that. I guess part of me thinks that if I've been on these drugs for 2 years now, and the T cell count is perfectly fine, he's undetectable viral load, he's taken his meds, I'm assuming he's growing and thriving?
He is. He's doing pretty well.
Yeah, I think it's gutsy no matter which way you do it. I just want to know, when he was on the steroids on the second round, did he get better?
Well, no. He's still, we were still dealing with these suppurative lesions, and it was, I guess, only in this last, well, in fact, he still had recurrences, even in the last year, so of abscess formation, new abscess formation.
And I guess the other question, is there anything else immunologically going on with him that's not HIV?
Not that we were aware of. Well, actually, it's a very good question, because in fact, we did start thinking about that, as you'll see at the bottom of this. So what happened was that actually Mark and Helen Arabi and others gave us some advice, and clearly they have, this happens, and that surgical interventions don't really solve the problem, and the only situation in which you had stopped the antimycobacterial drugs was when it was a much more localized disease, and Helen gave us this description of using some medieval poultices, but of course that was for TB, and anyway we weren't dealing with infectious material at that stage, but we were not brave enough to stop the antimycobacterials. In fact, I've got a second case which I haven't got time for, which was educating us at the same time about stopping too soon. And at that point, we were really thinking about your question, is there something else going on here? And we arranged interferon gamma IL-12 pathway assays, which was difficult because of the HIV. Most of the labs wouldn't do it. We finally found a lab in Cambridge that would do that, and other cytokine profiles. And he has got impairment of his interferon gamma production. And so, hot off the press, as of yesterday, my colleague Hermione Lyle has actually started a therapeutic trial of exogenous interferon gamma, and I don't know what the outcome will be, but we honestly did not have the guts to stop his treatment, and maybe we should have a show of hands from the audience.
I don't know. I think Anna had a comment.
Thank you, Gareth. That's very exciting to see the progress in this case. But when we 2 years or 2 years into treatment and things are not working, then you start thinking about treatment failure. And usually with mycobacterial infections, there are like 5 reasons you're going through. Is it adherence? It's not the case. Is it levels? Not the case. Is it resistance? Because you've been on the same drugs for a long time.
We're not growing it. I don't see that it can be resistant.
But potentially, like, you know, because if you're exposed to the same drugs with the slow infections for a year or longer, you can develop a secondary resistance on treatment. Is it immunological problems, and whether it's uncontrolled iris, or on the other hand is, I mean, here it's obvious immunodeficiency or specific immunodeficiency to TB. Yeah. And then the fifth cause is it something else that you are missing? But yeah, so here I would think resistance, no, then immunological cause.
Okay, thank you very much.
Thank you. Any other comments, last comments on this patient? I think in retrospect I wouldn't have stopped actually seeing the virus, you know, but anyway, that's too late to say that now.
No, in fact, you said keep going.
Yeah, I can't remember.
Yeah. I mean, I think that we need to be thinking about these kind of issues more. I'm sure this is a secondary phenomenon. I don't think we understand it very well. I'm sure this child hasn't got a primary defect in their interferon gamma pathway. Certainly there's no problem with the interferon gamma receptor, and we haven't found any of the known mutations genetically to explain this. So there's stuff that we don't yet understand about what the problem is here. But if we can use exogenous interferon gamma to help this child, well, it's probably worth proof of principle to try it.
And the test was done on steroids, this one?
Sorry?
The child was on steroids at the time when you did the test.
Thank you, Anna. No.
I'm just teasing, thank you.
Okay, thank you very much to Linda and Gareth for challenging cases.